My name's Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas, Nevada. I'm here with Dr. Bob Kushner, and he's with the Feinberg School of Medicine in Chicago, Illinois, professor of medicine there. And you're going to be talking about obesity and some of our options, our therapeutic options here in a few hours. But you want to tell us what you're going to talk about?
Sure. What I'm going to be focusing in on is the use of medication as well as the use of bariatric surgery for patients with obesity that find it difficult to control their weight with lifestyle alone.
Okay, can you define those, about like BMI or anything else?
We define the criteria to think about these interventions based on BMI or body mass index. So for medication, if you have a patient with a BMI of 30, which is obesity, or 27 or higher with a comorbidity, that's an indication to think about the potential use of pharmacotherapy. Now, since surgery is more invasive, more expensive, and there's a much greater commitment, there the BMI is higher. So there we think about a candidate as having a body mass index of 40 or more, severe obesity, or 35 with a comorbidity.
You know, we're at this meeting, we're talking about diabetes, hypertension, lipid issues. When you say comorbidity, I think that's what you're talking about, right?
Well, it is the cardiovascular comorbidities, heart disease, coronary disease, diabetes, hypertension. But there's other non-cardiovascular diseases that are obesity-related that we don't often think about that are that improve significantly with weight loss. Examples would be obstructive sleep apnea, fatty liver disease, GERD, urinary incontinence in a woman. It could be hypogonadism in a male. So there's a lot of non-cardiovascular illnesses that are obesity-related that have significant improvements if we get our patients to lose weight.
Do those, you know, I'm sure sometimes we have to convince our patients of taking a pill or, you know, considering a surgical option. You mentioned some of the non-traditional comorbidities. I like the one, hypogonadism. Can I talk a guy into getting some surgery based on hypogonadism? Well,
like any medical illness, or we're asking our patients to improve their behaviors and take better care of themselves. As good clinicians, we always link it to the chief complaint. So I may see a patient with a BMI of 38, class 2 obesity, and I'm thinking, if I can help you with your weight, a lot of things would improve. If I talk about that alone, it would probably not get very far. But if I link it to his erectile dysfunction or his lack of sexual interest, libido, and other medical problems, your knees hurt, you're sleepy, all of a sudden I have his attention, and then I can talk about the underlying issue there, which is his weight.
Okay. Do you do primary care, or you primarily get these patients as referrals?
So I run the Center for Lifestyle Medicine at Northwestern in Chicago. So it's a consultative practice. That's a team-based approach, focused in large part on obesity care. So I work with dietitians, health psychologists, nurse practitioner, physician assistant, and myself, and so on. So patients are referred to us generally with a comorbid condition. Let's take sleep apnea or diabetes, where the primary physician sees the patient's obesity as an important underlying problem, but doesn't have either the competence, the resources, the knowledge to really tackle that in a serious manner, medical manner. So they'll refer the patient to us. So all the patients I see know that their weight is an issue, but don't know how to approach it. And that's where we come in and take care of that.
Well, what kind of job can I do is if I want to refer a patient to you, a lot of times, I feel you probably agree, that success in your consultation is based a lot upon how I prepare the patient. How can I prepare the patient to best take advantage of you?
That's a great question. The first thing is you want to be proactive. And that is that you want to put it on the problem list. You want to raise it as an issue with the patient. You want to reinforce to the patient that their weight has an impact on their overall health. And that a small amount of weight loss, as little as 3 to 5% weight loss, particularly like for diabetes, can make a big difference. And if you only had the right strategies and knew what to do and the right referrals and resources, we can empower you to do something about it. And I have a program that I would like you to go to that can provide that kind of support. That's the patient who I see.
Should I, as a primary care person, first try, send it to a dietitian, try a lower medication?
Yeah, I think clinicians can do a better job. They can be part of the solution, as I say, not part of the problem. And that is, don't ask, don't tell. That's
Right.
so common when it comes to obesity care. So you want to assess, you want to acknowledge, you want to diagnose, you want to inform the patient. If you have the resources within your team, that's fine. You want to refer a patient to a commercial program, that's fine. Internet program, that's fine. You have to visit summary, resources, that's all helpful. Registered dietitian, those are all the resources a primary clinician can use if they're at the time themselves. I think that should be the first phase. There's way too many individuals struggling with their weight, so I'll go to an obesity specialist myself. So there's so much more primary care clinician can do to provide the support, resources, and strategies that patients need to take care of themselves.
Obesity is usually a frustrating issue, especially if it's associated with comorbidity. As a diabetic, I know if their obesity improves, their diabetes improves. How do I handle your recommendation? How do I handle my frustration?
Well, you want to think of it as a chronic illness, just like diabetes or hypertension. It's not like a rash. You don't just prescribe something and it goes away. It is very likely going to come back off and on over the lifetime of that patient. So you want to be prepared to think of it as a chronic relapsing disease. Number two, you dose the patient with information slowly and continuously. You're looking for improvement, not perfection. You want to provide strategies to the patient, not just education. So many patients I see say, my doctor's told me for years I need to lose weight. And then I will say, has your doctor given you the strategies? And they'll go, no, they just say try harder or try it again. Well, that's futile. And I think that feeds into the clinician that nobody changes because no one listens to me. Your goal is to be an advisor and an aide, not a prescriber when it comes to obesity. So a little bit of a mindset like that makes a difference.
Great. Well, that's very interesting. I'm going to look forward to your presentation.
I look forward to giving it.
Thank you.